So now we're going to talk about sex, and we're going to talk about puberty too. Now, how did I get into this fix of talking about sex? I was explaining this to Dr. Rizzo earlier today, and Dr. Porter explained to them why Dr. Elias talks about sexuality. Back many, many years ago now, something like 20-something years ago, 22, I think, I was one of the original authors on the first clinical report that was published that discussed sexuality in people with disabilities. It was a topic that people were embarrassed to think about, didn't want to talk about, didn't know how to talk about it. So a colleague of mine, Nancy Murphy, and I, who were members of the Executive Committee on Children with Disabilities for the American Academy of Pediatrics, were asked to write a clinical report on the topic of sexuality in people with disabilities. When you write a clinical report for the American Academy of Pediatrics, it's a pretty big deal. A lot of research goes into it. You get to review 100+ papers, and then what you write has to be sent to, seemed like, 1 million committees within the academy to make sure that they approve and agree with what you say before they'll allow it to be published. So it's a whole big complicated process. And then when it finally does get published, which can take sometimes 1 to 2 years to get it all finished, you get to talk about it at one of the big National American Academy of Pediatrics meetings. So that's when I gave my first talk on this topic now about 20 years ago. And one of the funny things about it was I have 3 children. One's a math professor, one's a physics professor, and our middle son has autism and special needs. And he asked me, as I was writing that paper and starting to give these talks all around the country, he said, "Mom, how come you're an expert on sex? You and Dad have only done it 3 times." So I told him, well, I'm kind of a fast learner. But I was actually really relieved at the time to know that he understood that there was a relationship between having sex and making babies. I thought that was a good thing. But it's an important topic, and I'm going to talk in this last talk about some of the things that we've learned. We recently, over the last few years, had to update and revise this clinical report. So the most recent version of it was just published by the Academy. It was a few years ago, but it was during COVID, so we didn't have the talk right after. I'm actually giving a talk on this at the American Academy of Pediatrics meeting that's coming up in September. And I've given many, many talks on this over the past 20 years, so it is one of my favorite topics. Here we go. So I modified this talk a little bit for this meeting because if you look at the community of people with disabilities, the broad community of people with intellectual disabilities of all causes, the vast, vast majority of people with disabilities have disabilities in the mild range. With Smith-Lemli-Opitz, there's a big spectrum, but many patients have disabilities in more of the moderate to severe range. So I'm going to include the information for people who have more mild disabilities and talk a little bit more about people whose disabilities are more severe, although the same principles do apply. And then just a caveat when I do the part of this talk that discusses puberty is that patients for any cause that have abnormalities with their sex hormones, or and particularly if your cholesterol level is really low and you can't make enough sex hormones, that can impact the timing of puberty. So sexuality is a very important concept. It's part of being a human being, and it's normal and it's healthy. And everybody has the right to be a sexual person, but there are certain situations that this may require some special attention, and that could be management or training or teaching. So what does a person need to have and to do to become a functioning sexual being? Well, the person, and this starts in childhood, has to understand body changes and what they mean. Are they a boy? Are they a girl? Anybody know when that knowledge comes in normally in a typically developing child? How old do you figure out what gender you are? Toddlers, right, at around age 3, yeah. And then you need to learn how to do self-care and good hygiene to be a sexual person. So for a teenager with more mild disabilities, it's so important to introduce independence. And so what does it mean to be independent as a teenager with disabilities? Well, as much as possible, to be able to get yourself dressed, to be able to bathe yourself, and if you're female, to be able to care for your periods. And we call these things activities of daily living, or ADLs. And for a person with mild disabilities, they can learn all these things and do them pretty well. You also need to learn how to advocate for yourself. So if you're in a position that's uncomfortable or maybe even compromising, who do you go to for help? How do you tell somebody, no, that's not something I want to do? And how do you protect your own independence? How do you behave differently in different social situations? Can you do the same thing in the privacy of your bedroom that you can do at school, or when your family goes to some, church or synagogue? You need to learn who you can trust and communicate with, and how to get help if you need it. And that's what it means to be independent. It can take a long time for this to happen, even in typical teenagers, some of them, and especially if a person has disabilities. So sexual orientation is a really big topic these days in pediatrics, and some of the rights and respect of people who have gender differences are not as well protected as they used to be. And again, I don't work at the NIH. I can say whatever I want to about this. But we don't know what the true incidence is of gender dysphoria. Gender dysphoria is you're born one sex, but you feel like you're not comfortable in your own body and you'd rather be the other sex. And transgender issues are sort of more appreciated these days than they used to be, I think. I mean, for a long, long, long time in our society, in our country, you didn't tell anybody, you didn't admit to these things, and now it's much more obvious. We have no idea, really no idea, because there haven't been enough studies about what the true incidences of gender dysphoria in people with more mild disabilities. We're assuming it's similar to the general population, but we just don't know, and we have no clue at all, never been studied about what this incidence is in people with Smith-Lemli-Opitz. So as I mentioned, the typical age that you discover what gender you are is around 3. And some children may have this sense differently, especially if if there are anatomic abnormalities involving the genitalia. So as you heard yesterday, some people with Smith-Lemli-Opitz have genitalia that are not normal, and there are some genetic males that actually have genitalia that are not clearly male. It's called ambiguous genitalia. And there are lots of causes of that. SLOS is not the only one. But we do know that if you have abnormalities of your genitalia, it can be more difficult to appreciate your true gender identity. But it's really important for a child's self-esteem to accept and appreciate and do appropriate teaching about what that child's sexual orientation might be. So experientiality, that's a hard word to say, had to practice it. What does that mean? It means that you have experiences in your life that teach you things. So a typical teenager might go to the mall with her friends and buy clothing that she thinks is attractive, doesn't want her mom to buy her clothes anymore. All of that sort of goes under sort of normal development of what is accepted, how you interact with your peer group, and that's how people learn. But if you have a disability, you might not ever have that experience. You might never have a date. You might never go to sleepaway camp and learn a lot of things your parents were never going to tell you. You might just never have those examples that will teach you how to do it. So we have to go out of our way to teach kids with disabilities about sexuality. And there are good curricula available to teach this. And when your kids are older, like when they get into middle school and into high school, teaching about sexuality should be part of their IEP and their educational curriculum. And it could be as simple as, you need to go to the boys' bathroom, you need to go to the girls' bathroom, or what is appropriate behavior. Can you just go out and touch another person any place on their body that you want to? No, you can't. Can you just touch any part of your own body any place that you want to in a public place? No, you can't. So you have to teach these things to kids, just like you've taught them how to get dressed and how to brush their teeth and how to use utensils. You have to teach children about behavior too, and what's appropriate and what's not appropriate. So I get a lot of questions about masturbation, for example. Masturbation is a very normal behavior when you're 3 and you're discovering your genitalia and that it feels good to touch them. It is not accepted when you're 16 and you have the body of an adult and you're masturbating in your classroom or the supermarket. So you have to teach these things to children. And if you can, enable children who have more mild disabilities to have some of these experiences that are typical for adolescents. I've had many, many patients with mild disabilities who've been able to go out on dates, supervised with a parent there, but, a parent who's driving them someplace so that they can sit in the movies together and hold hands. That's wonderful. And I have many, many patients with SLOS who come in and tell me about their girlfriends and their boyfriends, but they're having supervised activities that still give them the sense of things and keeps everybody safe, but they still have that exposure. We have to teach about safe sex and birth control, particularly to females who might get in that situation where they're not always protected by their parent or teacher, and things can happen. And privacy is critical. I never examine a patient with the door wide open. I always ask, do you want your parent to stay in the room, especially if it's a opposite sex parent, or do you want me to bring in my nurse so I can examine you with some more privacy? It's give a patient a gown to put on so that they don't have to lie there naked. It's very important for me to do physical exams on my patients so I can see what's going on, but I try to maintain and protect privacy as much as I can, because the person feels better that way. They feel respected as a person. Hygiene and grooming are really important, and teaching how to do that, and sometimes it takes years, and it takes repetitive teaching over and over and over again. Some things are like common sense, and they sound so simple and easy, but if you want your kid to be independent, get a consult about what's appropriate clothes for that age child. Ask your other kids. Ask somebody else in the neighborhood to help you if you don't know, and then find clothing that is easy to get in and out of so that people can be as independent as possible. Some kids never learn how to do buttons or zippers or tie their shoes, but they can learn how to do Velcro, right? So if you can find clothing that's as easy to use as possible, that helps with independence. And kids, there have been a number of studies that showed that kids who are dressed appropriately just feel better about themselves, and then arranging peer activities as much as is possible depending on the functionality of your child so that they can have more normal experiences. So behaviors are tricky and challenging very often, but you can teach children. Many of my patients with Smith-Lemli-Opitz have eventually become toilet trained and have eventually learned appropriate behaviors. I mean, sometimes families are very, very comforted to know that, masturbation is a common activity depending on your developmental age, not so much your chronologic age. And then it's important with older patients to teach about things, like smoke and drinking and drugs, because they're out there, and sometimes people really want to fit in, and they might be encouraged to take something that's dangerous by someone who thinks it would be funny if they saw some kid drunk or on pot. So it's important to teach kids that some things are safe to take and other things are not. There are good programs that teach sexuality to children, and children are able to learn these things at all different levels. I mean, this isn't taught to kindergartners or first graders, right? Typical kids get the sex courses in like 5th or 6th grade. So if you have a child with disabilities, they might be getting this in high school or the end of junior high, but there's some things that are just important to talk about. There are a couple of resources, and hopefully you'll be able to get my slides. They were sent, so I think they're going to come up on the website eventually. But, there are important things to teach about personal independence and care, social etiquette, body parts, feminine care. Puberty changes can be very, very scary for kids who don't understand what's happening. Relationships, sexually transmitted disorders or STDs. And then there are certain rights that you have and responsibilities that you have if you're going to be a sexual person. All right, to protect your partner from STDs and from pregnancy. So there are huge disparities in our culture about sexual education, and there are a number of studies. I cited a couple of them here for people with mild disabilities, that they never have gotten this kind of education. They're never taught about unsafe sex practices. They don't have anybody to talk to about it. Sometimes their parents are embarrassed and they feel like they can't go to their parents. A lot of teenagers go to their peers and get not quite correct information. And they just don't feel well about themselves. They're people who are, still incontinent, and incontinence makes it difficult to be a sexual person. And then women with intellectual disabilities, when they're adults, they don't always get the kind of GYN care that they need. They don't always get pap smears, or they don't always get mammograms because it's just really super hard. My husband's a breast cancer doctor, and as kind and compassionate and so on as he is as a physician, he has no clue what to do for my twins I take care of who have severe intellectual disabilities, whose mom had breast cancer in their 20s. They're supposed to be getting mammograms at their age because they're at risk. They're in their 20s now. And there ain't no way that even I can get near them and do a full physical exam. And I'm pretty good at that after all of these years. But any procedures that some patients need to happen under general anesthesia, and so they require special planning. But it's very, very hard for people in the disabilities world. They don't always get the care that is recommended. So this is a sad slide, but it's true. And people with disabilities have an increased risk of being the victim of sexual abuse. So this can be, I'm sorry? Yeah. So especially, if they're an attractive patient and their disabilities are mild, and they haven't had the sexuality education of, stranger danger and what's safe and what's okay and what's not okay, and when you can say no and when you need to ask for help. There's so many people who haven't had that teaching, and are at absolute risk for all kinds of abuse. There can be cyber solicitation, it can be online abuse, it can be physical or sexual abuse. And this can happen in day programs. This can happen in high schools. And parents think they're going to be able to protect their child forever, but really you're not. So being able to do education for your child with disabilities is the responsibility of us doctors, of your child's teachers, but also you as parents, and patients themselves when they are able. So let's go on to a more fun topic. Let's talk about puberty. So the normal onset of puberty for girls is 8 to 13 years, for boys is 9 to 14, so girls start sooner and end sooner. Puberty affects lots of things. It definitely impacts growth velocity. So kids going through puberty, that's when they grow the most in their height, okay? And it can absolutely impact and cause worsening behaviors, and can cause seizures to be worse. Most people have a normal onset of puberty if they have ADHD or autism or mild intellectual disabilities and their nutritional status is okay. Some of those things might not be the case in kids with SLO. Some kids with neurologic problems go through puberty early. So if there are malformations of the brain, I've had girls who've had their periods start when they're 8 or 9. And once you go through puberty, your growth plates are closed, so you're not going to get any taller. You're going to end up being even shorter than you might be otherwise if you have early puberty. And then late onset of puberty is common in people who have poor nutrition, hormone deficiency, sex hormone deficiency, and then certain psych meds can raise the level of this prolactin, which can impact onset of puberty. And so depending on what meds your kids might be on, we follow prolactin levels and sometimes need to adjust medication if the prolactin level gets too high. I have a slide on menstrual suppression. I do this a lot in in my patients. Why do you need your period? You need your period to come when you're ready to start your family and make babies. Do you need your period if you're a young lady in diapers in a wheelchair who's nonverbal? You're not making babies. You don't need your period. So it interferes with the ability to be independent because it's really a pain. Losing, when you have your period every month, you not just lose blood, but you lose iron. You heard about ferritin, checking ferritin levels, which I do all the time because I'm called Dr. Dracula and I get blood all the time. And one of the things that I check is ferritin. A lot of my female patients are really severely iron deficient and they can't sleep. And I can give them iron and help them sleep. And I can stop their periods and stop them from losing more iron. I do this a lot. For people who can swallow pills, we can use oral contraceptive pills to stop periods. They're very easy implants, Nexplanons you can put under the skin in your arm. We used to do a lot more Depo-Provera, which is a shot every 3 months. But because this can really impact bone density and lead to fractures, we use Depo-less. And then there's a long-term option that I do a lot, which is putting in an IUD. An IUD that's hormone releasing lasts for 7 years, and so you do it and you're done. It often requires general anesthesia in a patient with SLO, but it's a nice way you can do it and not worry about it for a long time. And here's my slide about HPV. Do I recommend it in people with Smith-Lemli-Opitz? I recommend it in everybody. You get this virus from sexual activity. Do I think a lot of my patients are going to be sexually active voluntarily? Some of them, yeah, if they're more mildly impacted, are definitely sexually active. But some of my patients with more severe disease, because of the increased risk of sexual abuse, I just want to protect everybody. If you get this shot at younger than the end of your 15th year, you only have to give 2, 6 months apart. If you wait until you're older, you have to give 3 HPV vaccines. So I really try to give it at a younger age. And again, people with mild disabilities are sexually active. They become sexually active. Sometimes they don't quite understand what's happening, but they do it because they want to be accepted and they want to have friends. And if they haven't had good teaching about safe sex, then they're at risk. So I have a longer conversation about this with parents whose children have more severe disabilities, because unless something bad happens to that patient, the likelihood of their having sex is much, much lower. I still try to convince it just because the cancer is so horrible. I wanted to spend a word about sterilization. Sterilization is a permanent procedure which prevents a patient from becoming pregnant. That could be a hysterectomy or tubal ligation, and in males they can do a vasectomy. Sterilization is a decision that's made not by the patient, but by the caregiver. And every state has different but very strict rules about when it's okay to do sterilization. I've had patients who have had this happen because they've had horrible menstrual cramps, severe iron deficiency anemia, terrible pain and discomfort with their periods, and it's just been that have been difficult to control with medications, and parents elect to want to do that. Or in some families who carry other genes that predispose to cancer, there's a very high cancer risk, and so sterilization has happened in patients who are at increased risk for cancers to prevent those. In years past, sterilization was was used in individuals with disabilities against their will and knowledge, and so we don't do that anymore in our country, and we shouldn't, of course. But if you're ever in a situation that you need to discuss that, it's a whole big thing with an ethics committee involvement to be able to do it, and depending on where you live, it's different. So that was my last slide, and then I have a whole bunch of references for you, and I'm happy to take questions.
Any questions? Here's one here.
Would you recommend a vasectomy for a 20-year-old?
Not necessarily. If that 20-year-old is in a situation where they're not likely to engage in sexual activity, it depends on the functioning level of the patient. One of my patients is the product of parents who had severe mental illness, and they were, both parents were hospitalized in a psychiatric hospital, and the father managed to get the mother pregnant. They had a baby with SLO that they were never able to care for, so the grandparents are caring for that young man now. People get into all kinds of situations you're not expecting. I think of it more for my female patients because I'm worried about they're being raped or getting pregnant. A vasectomy is not going to prevent an HPV infection, of course.
Well, I was just worrying about him. He's low functioning, experimenting,
Yeah.
what I'm saying?
Yeah, it's a very,
he's a boy.
Yeah, there have not been good studies on what the fertility is of males with SLO. I've read a lot of papers on fertility and different kinds of genetic disorders. For example, males with Down syndrome and females for that matter, are usually not fertile. But with SLO, there's just no information. If there are abnormalities of the genitalia, it's less likely that the patient could be a sexually functioning male and ejaculate and introduce sperm into a female, but we don't know the data.
How long do they go through puberty? I'm just being for real. I mean, my oldest is 15, and he started puberty. Well, he started developing pubic hair at 7. And now my almost 12-year-old, he started developing it at 9. And I'm just wondering, having two going through puberty, how long is this going to last, and how in the heck am I going to make through it?
Yeah. These are two boys?
Yes.
Yeah. So pubic hair can develop. Are they in diapers? Are they still in diapers? Yeah. So the skin around your genitals is kind of fragile, and diapers are not as soft and gentle a fabric as underwear. So it can be a protective mechanism of the body to develop hair in the pubic region in kids who are in diapers for years, but that's not true puberty. Hi, Juki. In girls, the first sign of puberty is development of the breasts. That happens first. And then you start to see hair in the pubic region. And then those things grow. And then it takes about 2 to 2.5 years from when you first see those signs in girls and they get their periods. So the average age in girls to start seeing those changes is around 10. The average age in girls to get your period is around 12 to 13. In boys, they're a little later. So the average age to see sexual changes starting 11 to 13 age, and what you see first in males is much more subtle, because the first thing that you see is enlargement of the testicles and enlargement of the genitalia, and it's kind of very slowly progressive, and so you might not even notice it right away, and then one day you look and you'll go, oh my gosh, this looks like a man, and it's definitely not looking like a baby anymore, but it's just much more subtle. You'll also generally see a growth spurt that goes along with the early stages of puberty. That's when kids achieve their fastest rate of linear growth. And so in boys, there's a lot that happens first. There are some changes in the genitalia where things are bigger, and then you get more hair on your body. And then the last thing that you'll see is sort of facial hair and the need to shave. And then once you get to that point, things are pretty much done. And in boys, it can be later in teenage years that you see the final pubertal changes. But through all of that time from when they're starting, there's more and more testosterone that's in the body. And it might take a longer time for kids with SLO whose cholesterol levels are not that high, because remember, you need cholesterol to make sex hormones.
What are some of the causes of early onset puberty?
Mm-hmm. It's more, well, first let me say we don't know what causes puberty to start in anybody. We don't know what the triggers are, but some triggers are abnormal brain. So kids, I used to be the medical director of the spina bifida clinic when I practiced in Boston. Kids with spina bifida often have hydrocephalus. So changes in pressure in the brain definitely can start early puberty. Any kind of brain malformation is associated with early puberty. So those are commonly seen in kids with Smith-Lemli-Opitz syndrome. But we don't know all of the reasons. There can be estrogens in certain foods, yeah. But it doesn't usually cause a pronounced change that looks like real puberty, yeah. Sometimes I'm not sure, and I'll send my patients to see endocrinology, and there are some hormone tests you can do to tell you if the kid is really in puberty. I also have gotten an x-ray of the wrist, the left wrist. It's called a bone age, because puberty that comes early is often associated with an advanced bone age. And so the kid might be only 8, but their bones look like they're 11 or 12. So their body thinks they're 11 or 12, and it's going through the changes you might anticipate for a kid that age. So, yeah.
Our endocrinologist had asked us if we had considered using hormone blockers on Jack, our 11-year-old. This was just this last year. And
For early puberty?
I was kind of shocked, and I'm like, what? And,
Yeah.
And he said just to make it easier for the caregiver in size and
Yeah.
aggression and whatnot.
The main consequence of early precocious puberty is short stature. If you have Smith-Lemli-Opitz, you're likely to be short anyway. And sometimes if your child has more severe disabilities and is still needing lots and lots of help from you for all their activities of daily living, it's kind of easier if your child is smaller. And in fact, there are programs around the country that actually give hormones on purpose to accelerate the pubertal process, to have the child with severe disabilities go through puberty on the early side on purpose to end up with a smaller size person who's easier to care for. And that is an accepted practice. Not everywhere, but it's definitely an accepted practice in my hospital. It's called growth attenuation is the name of that practice. It had a very sad start. It was done by a family with their child from Seattle, and they put the whole process out online and social media. They called their child a pillow angel. In addition to giving her lots of high-dose hormones to get her to go through puberty at a very early age so that she could remain a very small person and they could care for her more easily, the child also carried cancer predisposition genes that would lead to her getting either breast or ovarian cancer. So after a whole big ethics meeting and working with their endocrinologist, they decided to not just use the hormones, but to actually do surgery to remove the child's breast and her female reproductive organs because of the risk of cancer that they felt would be difficult to screen for. And this was all on social media way out there. And people in this country, in the disabilities community particularly, went absolutely ballistic about this. And there were so many negative, horrible things said about the doctor, the endocrinologist who was treating this patient, that he committed suicide. It was horrible. He was a close friend of the head of endocrinology at my hospital, and we were all horrified, those of us who care for people with more severe disabilities, because this is a personal decision. It's between a family and their doctor, and it's nobody else should ever weigh in on a medical decision that you're making as an informed and smart person who loves your child. You are the people who decide that. It's not out for anybody on social media to judge you and decide that you've done something bad. They did it right. They did an ethics consult. They had a whole huge conversation about it, and they still received a whole lot of horrible negative attention for that decision. So growth attenuation got a bad rep. It's helpful for certain patients under certain circumstances, and I support my families who have made that decision after they've made it, given all the medical information, and that they need to make an intelligent, wise decision for their child.
Thank you, Dr. Ellen Elias.
You're welcome.